welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
We have Iram, Nasreen, who is a PGY2 resident at Rush University Medical Center. Today she'll be presenting a journal club on intensive ambulance-derived blood pressure reduction in hyperacute stroke, the INTERACT-4.
All right, thank you for the introduction. We'll go ahead and get started. I have no conflicts of interest to disclose. I am going to start with some background information. An acute stroke is an interruption of blood flow in the brain, and the lack of oxygenated blood can lead to cell death. Here in the United States, there are approximately 795,000 strokes annually, leading to significant morbidity and mortality nationwide. And of those strokes, about 87% are acute ischemic strokes, meaning that a clot is blocking blood flow in the brain, and around 13% are hemorrhagic strokes, meaning there is bleeding in the brain. And of those, around 10% are intracerebral hemorrhages, and around 3% are subarachnoid hemorrhages. And for both ischemic and hemorrhagic strokes, hypertension is a common risk factor for stroke, and blood pressure is commonly elevated at the onset of stroke, and it can be an independent prognostic factor for poor outcomes. And although we know this, the optimal approach to acute blood pressure management in this patient population is uncertain, and the nuances between different stroke subtypes adds further complexity to this. For the ischemic subtype, I'm going to go through the mechanism of injury and how blood pressure plays into it. So in an acute ischemic stroke, a clot obstructs blood flow to a specific area of the brain. And on the left-hand side of the screen, you can see that there's a darkened region that represents the ischemic core, and that's where brain tissue is irreversibly damaged due to the lack of oxygenation. And then surrounding this is a penumbra, and that's an area of compromised but still viable tissue. And salvaging as much of the penumbra as possible is really the primary goal for our therapeutic interventions. So when we give thrombolytics or perform thrombectomy, the goal is to restore that blood flow and save that part of the brain. And if we're not giving thrombolytic therapy or thrombectomy, then one potential way to protect the penumbra is to attempt and salvage brain tissue through permissive hypertension, which means that because you want blood flow to the brain, and it's based on cerebral perfusion pressure, which depends on your mean arterial pressure, and that is really just your systemic pressure. And it also depends on your intracranial pressure, which is the pressure inside of your skull. So since ICP, the intracranial pressure, is generally stable in acute ischemic stroke patients, then maintaining a higher MAP could enhance your cerebral perfusion pressure. And so elevated systolic blood pressure may therefore play a beneficial role in preserving blood supply in the penumbra and preventing further damage, theoretically. And then according to the 2019 AHA and ASA guidelines for the early management of acute ischemic stroke, hypotension and hypovolemia should be corrected to maintain systemic perfusion levels necessary to support organ function. And the blood pressure level that should be maintained in this patient population to ensure the best outcome is really unknown. There are some observational studies that show an association between worse outcomes and lower blood pressures, but then there are some that don't. So we don't really have any direct or hard evidence that supports a specific goal. And patients who have elevated blood pressure and are otherwise eligible for treatment with IV alteplase or other thrombolytic therapy should have their blood pressure carefully lowered so that their SBP is less than 185 and their diastolic is less than 110 before giving IV fibrinolytic therapy. And that's really based on how the drugs were studied and the theoretical risk of higher rates of hemorrhagic conversion if you're having a higher blood pressure when you're administering these drugs. And in patients for whom mechanical thrombectomy is planned and who have not received IV fibrinolytic therapy, it is reasonable to maintain your blood pressure less than or equal to 185/110 before the procedure. And this is to prevent the risk of having reperfusion injury if an area that had not enough blood flow now has a lot of blood flow. And the usefulness of drug-induced hypertension in patients with acute ischemic stroke is not well established. There is some studies and data on use of vasopressors in this patient population, but nothing really to suggest a strong benefit. Now we're going to switch gears and look at intracerebral hemorrhage and how blood pressure would play into this. So we can think of intracerebral hemorrhage in terms of two phases of injury. There's primary injury, which occurs immediately due to the bleeding, and secondary injury, which develops over time as the body responds to the hemorrhage. For primary injury, this occurs within the first 6 hours of insult. And as blood accumulates in the brain tissue, this is called hematoma expansion. And this results in increased intracranial pressure. And this is because you have a rigid skull that can't really accommodate for the expanding hematoma. And that causes your ICP to rise, which then reduces your cerebral perfusion pressure and impairs blood flow to the brain and worsens your ischemia. There can be hydrocephalus from blood entering the ventricular system, causing cerebrospinal fluid flow obstruction and further increasing your ICP and compressing brain tissue. And there's also risk of herniation as a mass effect from hematoma, edema, hydrocephalus, and this can displace your brain tissue, causing herniation, including potential for brainstem compression, leading to your respiratory dysfunction that can increase your risk of mortality. And then for secondary injury, this can develop hours to days after your initial bleed, and it's driven by a complex biochemical and physiological process that includes mechanisms related to the cerebral edema, inflammation, and then toxicity from the blood products as well. So generally speaking, elevated blood pressure on presentation is associated with hematoma expansion, neurologic deterioration, death, and dependency. And since the risk of hematoma expansion is noted to be earliest during the first few hours after symptom onset, early research has tried to focus on gaining acute blood pressure control in attempts to reduce hematoma expansion and thereby try to reduce morbidity and mortality associated with it. And two of the biggest trials that help shape our understanding of the early blood pressure management in this patient population are INTERACT-2 and ATTACH-2. So INTERACT-2 was a trial done in 2013. It was a multi-center randomized study involving 2,794 adult patients who presented with ICH within 6 hours of symptom onset and systolic blood pressures between 150 and 220. Patients were randomized to one of two treatment arms, either targeting a systolic blood pressure of 140 within 1 hour versus a more conservative target of 180. And the choice of antihypertensive agents used were left to the provider's discretion. The primary outcome was death or major disability, which was defined as a modified Rankin score of 3 to 6 at 90 days. And the results showed a trend toward benefit with the lower systolic blood pressure target, with an odds ratio of 0.87. And although this did not achieve statistical significance and had a p-value of 0.06, but the trend was there. And then for the ATTACH-2 trial, this was done in 2016 and also investigated blood pressure management in ICH, but focused on a little bit of a different population. They studied 1,000 adult patients with ICH that had volumes of less than 60 centimeters cubed, a GCS score of 5 or higher, and a systolic between 150 and 220, and all patients presented within 4.5 hours of symptom onset. Patients were randomized to intensive systolic blood pressure targets of 140 versus standard of 180, and nicardipine was the agent that was used in this patient population. The primary outcome was death or major disability, defined as a modified Rankin score of 4 to 6 at 90 days. And the results showed no significant difference between the two groups with a relative risk of 1.04. However, there were notable adverse effects for renal adverse events within 7 days. They were significantly more common in the intensive treatment group at 9% versus 4% with a p-value of 0.0002. Although serious adverse events within 72 hours were rare and comparable between the two groups. So overall, these initial RCTs on intensive blood pressure control did not show evidence of improved functional outcomes for patients with ICH. However, there are some important subgroup and post-hoc analyses that can help us better understand the results of these trials. So for INTERACT-2, there was a subgroup analysis of functional disability that was assessed using ordinal analysis of the modified Rankin score. And the results demonstrated that patients in the intensive blood pressure target group, the systolic being less than 140, had lower MRS scores compared to those in the standard target group of 180. And the odds ratio for better functional outcome was 0.87 with a p-value of 0.04, indicating a statistically significant trend toward improved functional outcomes in the intervention group with the lower blood pressure goal. And then for the ATTACH-2 trial, they had a post-hoc analysis of patients who achieved the target blood pressure within 2 hours, so earlier on between all the patients overall. This included 913 patients, and the key findings include risk of hematoma growth. For the intensive blood pressure group, they had 56% reduced risk of hematoma expansion with an odds ratio of 0.56 and a p-value of 0.02. For functional independence, the intervention group was more likely to achieve functional independence with an odds ratio of 2.17 with a p-value of 0.004. And then the intervention group also showed a trend toward better outcomes at 90 days with an odds ratio of 1.68 and a p-value of 0.048, suggesting improved recovery with intensive blood pressure control. And so these outcomes highlight the potential benefits of early intensive blood pressure lowering in patients with ICH. So given the potential of early blood pressure control being able to help reduce hematoma growth and improve functional outcomes, there were 2 randomized trials that were conducted to evaluate the impact of early blood pressure management in the pre-hospital setting. So the RIGHT-2 and Mr. ASAP trials were both multi-center, pre-hospital, randomized, sham-controlled, blinded endpoint trials that evaluated the use of transdermal glyceryl trinitrate patches versus either placebo or standard of care in adult patients with undifferentiated suspected stroke and baseline systolic pressures greater than or equal to 120 or 140. And both of these trials evaluated modified Rankin scores at 90 days, and for subpopulations that included patients with ICH, neither of these trials found any statistically significant difference. And the Mr. ASAP trial actually showed trends towards increased mortality in patients with ICH, which led to premature trial termination. So although we hypothesized that early intensive blood pressure reduction would improve functional outcomes in patients with ICH, and we have some subgroup analyses that showed benefit, these subsequent RCTs did not show a benefit in this patient population in the pre-hospital setting. And then based on the current information that we had at the time, the 2022 AHA-ASA guidelines for management of intracerebral hemorrhage made the following recommendations. You should have medication titration to ensure smooth and sustained control of blood pressure, avoiding peaks and large variability in your systolic blood pressure. And this is really based on further meta-analyses that use INTERACT-2 and ATTACH-2 and other trials that found better functional outcomes among patients with smaller standard deviations in their blood pressure readings, suggesting that less variability improves outcomes for patients. Initiating treatment within 2 hours of ICH onset and reaching target within 1 hour can be beneficial to reduce the risk of hematoma expansion, which makes sense if the risk of expansion is early on. In ICH of mild to moderate severity, presenting with systolic blood pressures between 150 and 120, acute lowering of systolic blood pressure to a target of 140 with goal of maintaining in the range of 130 to 150 is safe and may be reasonable. And this is based on the average blood pressure readings that were achieved in the trials that we discussed. And if presenting with a large or severe ICH or those requiring surgical decompression, the safety and efficacy of intensive blood pressure lowering is not well established. And this is because a lot of those patients ended up being excluded from the trials that we talked about. And if ICH is mild to moderate severity presenting with systolic blood pressure greater than 150, acute lowering of SBP to less than 130 is potentially harmful. And that's based on the potential for renal adverse effects that we saw. So then looking at some newer literature that came out after those guidelines, the INTERACT-3 trial was published in 2023, and this looked at a bundled care approach for ICH patients using early intensive lowering of systolic blood pressure to a target of less than 140, strict glucose control, antipyrexia, and rapid reversal of warfarin-related anticoagulation. So although this is not specific to blood pressure control itself, it is included as part of that bundled care approach. And this trial found that likelihood of a poor functional outcome was lower in the bundled care group with common odds ratio of 0.86 with a p-value of 0.015, again showing that having early intensive blood pressure reduction would be beneficial in this patient population. And this leads to our current day recommendations from the 2024 AHA-ASA Code ICH guidelines, and these recommend to continue having a systolic blood pressure goal less than 185 and diastolic less than 110 for patients with acute ischemic stroke who will receive thrombolytic therapy. And for ICH patients, the guidelines recommend an SBP less than 140 to 160 and no specific time metric or agent to be used. So then this brings us to the trial that we're going to be evaluating today. Intensive ambulance delivered blood pressure reduction in hyperacute stroke. And the objective of this trial was to evaluate the safety and efficacy of initiating IV antihypertensive treatment in an ambulance within 2 hours of acute stroke. For the study design, this was a multi-center trial that was done in 51 different hospitals in China. It was a prospective, randomized, open-labeled blinded outcome assessment, with blinded outcome assessment meaning that those evaluating the patients for the primary outcome at follow-up were not aware of what intervention group they were in. And this was completed between March 20, 2020 through August 31, 2023. For inclusion criteria, they had patients greater than or equal to the age of 18 years. They had presumed acute stroke with a FAST score of greater than or equal to 2 with arm motor deficit as well. their last known well less than or equal to 2 hours, and a systolic baseline blood pressure of greater than or equal to 150. And they excluded patients who had coma, severe comorbid disease, history of epilepsy or seizure at onset of symptoms, a history of a recent head injury, and those with hypoglycemia, which they defined as less than 50 milligrams per deciliter. For their interventions for the pre-hospital blood pressure reduction, they had patients receive urapidil 25 milligrams intravenous push over 1 minute. Urapidil is a drug that is mostly used in China and other countries in Asia, and it blocks alpha-1 receptors and 5-HT1A receptor agonist as well. It has an onset of about 5 minutes and a duration of about 4 hours, and I think this background information is just important to understand why they would have chosen this for the pre-hospital setting. And they did allow the paramedics to repeat at least one dose in 5 minutes if there was inadequate response for their goal. And the goal they had for this patient population was an SBP of 130 to 140 in less than or equal to 30 minutes from randomization and maintaining that until at least hospital arrival. And then for their usual care group, they had blood pressure reduction after hospital arrival unless their systolic was greater than 220 or diastolic greater than or equal to 110. And the goal for this patient population was an SBP of less than 140 for patients who did have an ICH, and goal of 140 to 160, and diastolic of 80 to 90 in patients with acute ischemic stroke. That is a little bit different than what our guidelines recommend, but they were doing this based off of what usual care goals are from the 2019 Chinese Stroke Association guidelines, since this study was done in China. For study endpoints, the primary endpoint was looking at functional status, which was defined as based on modified Rankin score at 90 days. And for secondary endpoints, they were looking at death from any cause and cause-specific death within 90 days, neurologic impairment based on NIHSS at 24 hours and 7 days, disability, which was defined as a modified Rankin score of 3 to 5 at 90 days, hospital discharge by day 7, living situation, whether they were at home or an institution at 90 days, and then quality of life based on the EQ-5D3L patient-reported questionnaire at 90 days. And then for patients with ICH, they also looked at baseline and 24-hour hematoma volume seen on CT scans. For statistical analysis for power, they estimated that 2,320 patients were needed for 90% power to detect 22% lower odds of poor functional outcome in the intervention group, and they predicted having 6% stroke mimics and 5% patients with unavailable primary outcome data. For intention to treat, they had sensitivity analyses adjusted for pre-stroke function, sex, and time from symptom onset to randomization. For the per protocol group, they included patients who adhered to assigned treatment without meaningful protocol deviations. For modified intention to treat, this included patients with cerebral ischemia, whether that was acute ischemic stroke or TIA, or non-structural cause of ICH, and included patients with subarachnoid hemorrhages or stroke mimics. For ordinal logistic regression, this was used to evaluate the modified Rankin scores at 90 days for functional outcomes and for the questionnaire used to evaluate quality of life at 90 days. And then for subgroup analysis, they reported point estimates only and did not adjust for multiple comparisons. For enrollment, they randomized 2,425 patients, and of these, 21 were excluded, mostly because they were either unable to obtain consent or consent was withdrawn, and ended up including 2,404 patients. For the pre-hospital blood pressure reduction group, this was 1,205 patients and 1,199 in the usual care group. For baseline characteristics, there weren't any major between group differences prior to hospital arrival. The average age was around 70 years for both groups. Patients had a pretty equal distribution of around 24, 40, and 35% for their FAST scores of 2, 3, and 4. Patients in both groups were randomized by around 60 minutes from symptom onset. Baseline systolic pressure in both groups was 178 and arrived at the hospital around 75 to 80 minutes after their symptom onset. And unsurprisingly, the systolic blood pressure at hospital arrival was lower in the pre-hospital group at 159 as opposed to 170 in the usual care group that did not have IV antihypertensives given prior to arrival. There were similar prior medical history distributions for patients with hypertension, around 70% for both groups, previous stroke and coronary artery disease. There were more than double the patients with history of diabetes in the pre-hospital blood pressure reduction group. And then both groups had patients with median NIHS score of 13 with an interquartile range of 10 to 15, meaning that most of these patients ended up having a moderate stroke. And for diagnosis, there were around 50% of patients that had cerebral ischemia, 43.3% of both groups had hemorrhagic stroke, around 6% had stroke mimics, and less than 1% had uncertain diagnoses. This graph here shows the systolic blood pressure readings at all time points for all patients. The blue line shows the readings for the intervention group, so pre-hospital blood pressure reduction, and the red line shows the control group, which was usual care. I want to point out that although the goal was to have a systolic blood pressure reduction to achieve less than 140 prior to hospital arrival and maintain this, most patients ended up achieving somewhere between 140 and 160 prior to hospital arrival, with the mean being closer to 160. These are the results for the primary outcome, which was looking at modified Rankin score at 90 days. So the adjusted common odds ratio for all patients with undifferentiated stroke was 1, with a 95% confidence interval of 0.87 to 1.15. So there was not a statistically significant difference seen between groups. And then when you look at subgroup analyses for the primary outcome and the adjusted common odds ratio for poor functional outcome, there wasn't really any subgroup that had better or worse outcomes unless you're looking at the type of stroke. So when you're looking at the type of stroke for patients with ischemic stroke, their adjusted common odds ratio is 1.3 with a 95% confidence interval of 1.06 to 1.6, meaning that it was more likely for them to have a worse outcome if they had pre-hospital blood pressure reduction. And then for patients in the hemorrhagic stroke group, they had an adjusted common odds ratio of 0.75 with a 95% confidence interval of 0.6 to 0.92, meaning that it was more likely for them to have better functional outcomes if they did receive pre-hospital blood pressure reduction. And then looking at secondary outcomes, there weren't any major differences for looking at the modified Rankin score at 90 days for scores of 3 to 6 or 3 to 5, death within 90 days, the median NIH score at 24 hours or 7 days, or the quality of life that was reported from patients, or differences in the hospital discharge day 7, or whether they were living at an institution or at home at 90 days. And then looking at the safety results, there weren't any major differences between the groups. And for at least one serious adverse event, this was 27.5% for the pre-hospital blood pressure reduction group and 28.7% in usual care. But this does include mortality as an outcome for one serious adverse event, which was around 22% for each group. And then the other serious adverse events that were seen were things like sepsis and pneumonia. And then there was one patient with COVID-19 positive infection in each of these groups. So for the author's study conclusions, they concluded that pre-hospital blood pressure reduction showed no significant improvement in functional outcomes compared to usual blood pressure control in patients with acute stroke. However, there were better functional outcomes compared to usual care in patients with hemorrhagic stroke and worse functional outcomes compared to usual care in patients with ischemic stroke. So then going into the critique of this study for strengths, this was a multi-center randomized control trial. They did use standard pre-hospital stroke assessment scales with the FAST scores and their interpretation of it as well. They had standard functional outcome scales used for their primary outcome and appropriate follow-up period of 90 days, which is similar to previous literature that we evaluated. They did have balanced baseline characteristics. They did have significant timely blood pressure reduction with the intervention compared to usual care. They used blinded endpoint assessment for the primary outcome. This was powered for the primary outcome, and they had low rates of loss to follow-up. For limitations, one big one is representativeness of the study participants because this study was done in China and most of those patients were Chinese. And then when you look at the actual diagnosis for these patients, there were around 43% in each group that ended up having a hemorrhagic stroke, which is more representative of the incidence rate of hemorrhages in China as compared to here in the US. And it also could be related to the inclusion criteria because we were looking at patients with elevated blood pressure and who had early motor deficits specifically, which is more likely for hemorrhagic stroke over ischemic. And then another limitation is that their blood pressure targets in the usual care group were lower than AHA or ASA recommendations. So I don't know if the differences that they found would have been the same if compared for ischemic stroke patients here managed in the US. And then another big limitation is their blood pressure targets were not met. Although they did have a significant difference between groups, it wasn't the goal that they were looking for, a systolic less than 140. And the use of urapidol, although this is a common drug that's used in China and some of the literature that's published out there, it's not something that we have available in the US, so limits us in application purposes. And then the subgroup analyses only had point estimates, so it makes it hard to draw strong conclusions from this. And then there could be a potential impact from the COVID-19 pandemic on data verification for this because the people who were doing data verification did this remotely. So my personal conclusions from this are that this was the first randomized trial to demonstrate early intensive blood pressure lowering may improve outcomes with ICH. And I think this highlights the importance of protocols like Code ICH for rapid intervention. And although I wouldn't say that routine blood pressure lowering should be done in the pre-hospital setting when you don't know what kind of stroke the patient has, I would want to avoid doing that in order to avoid harm in patients with acute ischemic stroke. But I think this does make us want to be more aggressive about getting that blood pressure under control for patients who do have ICH, and we know this. For mobile stroke units, they could play a pivotal role in early ICH identification and early intensive blood pressure reduction in the future. They do have the ability to identify what kind of stroke a patient's having, and they do have the ability to carry drugs like nicardipine and be able to start that early on. But I do think there is still need for further research to develop rapid methods to differentiate between acute ischemic stroke and hemorrhagic stroke, especially because mobile stroke units are very expensive and not everyone's going to have availability for that. And we still need to determine what the optimal blood pressure targets are for acute ischemic and hemorrhagic stroke, especially because a lot of the trials look towards having aggressive goals of less than 140, but then they actually achieve closer to 160, and we're still able to have better outcomes with that. And then we still need to identify the optimal agents for acute blood pressure control in patients with ICH. Thank you to Giles for helping me put this presentation together. These are my references, and I'm more than happy to take questions at this time.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.